So I guess everyone knows Melanie. She's our star glaucoma uh, chief in down in Nuevo Progreso. She's also be starring our fundraiser in October or November, I think. Not sure yet, but Melanie, I had the honor of being with her in the OR, and she's an amazing surgeon.
Hmm.
Um, and yeah, she's just amazing. She does a lot of pictures and Instagram things, and she's I don't know how to do it, but that's all you. But and she listens to great music as well. She taught me a lot of great music. So Melanie, go ahead. The floor is yours.
Yay, thank you so much for that really kind introduction. So I'm so happy to be here with you tonight, and I'm gonna try to go like a little bit fast, but please tell me if you need me to go slower because it's like a very interesting topic and I learned a lot from making this presentation, and I want to share a lot of what I learned so that it can help you as it helped me. So I don't know if any of you know what type of flower this is, but I think it looks super pretty and like super like, nice white and so delicate, but as the presentation says, not everything is as it seems. So this is the case that I brought for you tonight. And to start with our case, we have a 48-year-old Hispanic female, and she came into the clinic the 18th of December of last year, and her chief complaint was diminished visual acuity in both eyes. She mentioned that her left eye was worse than the right eye. She mentioned that she occasionally had sorry, she occasionally had headaches, but they weren't too bad. And she also mentioned that in her past medical history that she went to different doctors, and one ophthalmologist mentioned that she had glaucoma in both eyes. She got PIs in both eyes, and she was currently using triple combined therapy of timol, dorzolamide, and brimonidine in both eyes twice a day. Past surgical history was negative, and everything else was negative. So she wasn't taking any medications and she didn't have any other complaints. So in her clinical examination, best corrected visual acuity on the right eye was 20/80. On the left eye was hand motion. And as you can see, the refraction does not really correlate with that really bad vision, especially in the left eye. IOP was normal in both eyes. She had 11, and extraocular movement range was full. The slit lamp examination showed a clear cornea, clear conjunctiva, a quiet AC, permeable PIs in both eyes, and the pupils. This is like what really like jumps up to attention, that the right eye had like a round reactive pupil, but with a sluggish reaction, and the left eye had an APD. Gonioscopy showed a fully opened AC angle. We could see up to the ciliary body band in 360 of both eyes. The lens was clear, and the eye fundus was described with a optic nerve with pallor of the neuroretinal rim and the CDR of 8.8 in both eyes. So these are pictures of the eye fundus of the patient that I mentioned. And as you can see, both eyes look with pallor of the optic disc, and she didn't have anything else in the retina or in the fundus that was like causing anything. Like she didn't have any scars or anything, or membranes, nothing, just the pallor of the optic disc. And what really like was curious was that the neuroretinal rim was actually like preserved. It didn't have she didn't have any thinning in the superior and inferior pole, so kind of like it doesn't really look like glaucoma. So at this point, my clinical impression for this patient was optic neuropathy. I had to study her a little bit more. And I left here the clinical impression of primary angle closure suspect because she has PIs in both eyes, but like she doesn't really look like one, but it's part of her history. So I left it there just to consider. And the plan for this patient was to get an optic nerve OCT just for documentation purposes. She was asked to get a visual field in both eye, in right eye, because her left eye was hand motion, so she wasn't going to be able to do a lot with that one. I also asked the patient to get a brain CT scan, and she was asked to come for follow-up with the tests done. So these are pictures of the report of the OCT of both eyes. And as you can see, we have a very, like a normal sized optic disc with a CDR of 0.82 on the right eye. And we have a very diminished average thickness of the RNFL, and the whole nerves looks like it's like atrophied. But as you like, what I mentioned before is what still calls like it's not, doesn't go well with the glaucoma diagnosis, is that the neuroretinal rim, the pulse superior and inferior, is not very thin. So that doesn't really go well with the glaucoma diagnosis. This is the left eye. Again, the disc is a normal size disc with a vertical CDR of 0.75. It doesn't really go with the visual acuity, the age of the patient, the IOP. So, and this is her brain CT, and this is what actually is the actual like diagnosis of our patient. She had a brain CT scan that described a solid heterogeneous tumoration with defined borders that highlights with administration of IV contrast. And it's a lesion that arises in the sellar region and projects toward the frontal region with a size of 41 times 39 times 43 millimeters. So it's quite a large mass. I don't know if you can see it there, but it's quite like visible there. So going back to the flower that I showed you at the beginning. So that cute white flower, it's actually the flower of the Venus flytrap plants. So they look like they are like super delicate, but they're not really. That's how they lure their prey, right? So just like this patient, she had a diagnosis of glaucoma. It looked like a glaucoma nerve if you're not like very experienced, but once you start like checking out the details, then you notice that it's actually not a glaucomatous optic nerve. So the diagnosis for this patient is, as a primary diagnosis, a craniopharyngioma versus a hypophyseal macroadenoma. Sorry, those words are hard to pronounce. And the plan for this patient was, first off, stop glaucoma medication. It's not glaucoma and she doesn't need them, and the drops, and also do a hormonal panel just to complete her workup, and referral to neurosurgery for a further plan of treatment for this patient. So when I was seeing this case in the clinic, it made me think of a very interesting concept in nature that is mimicry, right? It's when animals, plants, and other things, like they try to like use different characteristics like appearance, smells, to camouflage, or maybe to mimic something that they are not, just to keep their like predators away. And sometimes I think that this happens also like in ophthalmology, where you see stuff, but at first glance it looks like something, but it's not really. So this is a concept that I really find interesting, and that's why I'm gonna talk about glaucoma mimickers to you tonight. So it is very often that we see that patients are misdiagnosed with glaucoma, and it happens a lot more frequently than you might think. And this is it, since it is fairly common, you can see many times that there are a lot of patients who are using glaucoma drops who don't actually need them, right? So it's called to my attention that we've evolved to a point where people, they equate optic disc cupping to glaucoma. That is actually not true. Glaucoma is just one of many optic nerve processes that can cause cupping, right? So that's what we're discussing tonight. So as you know, glaucoma is characterized by a chronic progressive optic neuropathy with corresponding visual field changes with or without raised intraocular pressure. So when the IOP is high, it is relatively easy to suspect and diagnose glaucoma. And also there are optic disc or visual field changes that might mimic glaucoma, but they're not glaucoma, and we're going to discuss them a little bit further. So there can be optic disc anomalies, RNFL defects, visual field defects, and acquired conditions that can look like glaucoma, but they are not really. And this is another example of mimicry in the nature. This is the anglerfish. That's how he lures his prey. And as I mentioned, the appearance of the optic nerve head, the RNF changes, or the pattern of visual fields, they can make you suspect glaucoma, but they by themselves are not the only, like if you consider like a single parameter to decide on the diagnosis, then you can be wrong, right? So therefore, like it is important to understand that there are conditions that might mimic glaucoma, and they are broadly divided into optic disc mimickers and visual field mimickers. And so as I mentioned, it is important to be cautious about diagnosing glaucoma based on a single parameter. So we have to take into account all of the clinical picture, right? And here, so the appearance of the optic nerve is usually the starting point to suspect or diagnose glaucoma, right? So it is important to understand which are the typical features of a glaucomatous damage. And here they are. So the first one is enlarged CDR or cup disc ratio, CDR asymmetry of more than 0.2 between both eyes, considering that might not be like a very important inter-eye difference in size of the optic disc. This is something that I'm going to mention a little bit further down the road. And also another feature is neuroretinal thinning on the superior and inferior pole, as I mentioned a couple of slides ago. Another feature is focal or broad notch disc hemorrhages and RNFL defects. So talking about a little bit of each of those, large CDRs are not synonymous with glaucoma, as we mentioned. And it is like surprising to know that up to 20% of non-glaucomatous conditions are misdiagnosed and inappropriately treated as glaucoma when the physician bases his or her diagnosis only in the large CDR, right? So it's always important to assess the disc size along with the CDR when we are considering an optic disc. And because we can have people with physiologically large discs, for example, like in high myopia and several other neuro-ophthalmologic conditions. Optic disc cup asymmetry. CDR asymmetry can be present even in normal eyes due to an asymmetry in the optic disc size. Again, we always have to consider the optic disc size when we are analyzing CDR and an optic disc. And there are several congenital and acquired non-glaucomatous conditions that can cause unilateral large cupping. So we have to pay close attention to the overall size of the optic disc when we are considering the CDR and the asymmetry. And the next parameter is disc cupping versus pallor of the neuroretinal rim. So I see this very often. People tend to confuse a lot pallor and cupping, but they are actually not the same. So pallor, more than cupping, is a feature of non-glaucomatous optic neuropathy. There can be certain glaucomatous conditions that can be associated with significant pallor. For example, people with angle closure glaucoma or other secondaries glaucoma who develop acute rises in IOP that can cause ischemia as well, they can show pallor, but that is like, if you see pallor of the neuroretinal rim, then you probably should be considering non-glaucomatous optic neuropathies. Like, as I said, this is just one of the features, so you have to like add them on so to make your diagnosis. And optic disc hemorrhages. They are often seen in glaucoma, especially in normal tension glaucoma. So they are typically flame or splinter shaped, and they are perpendicular to the optic disc margin. So they are mostly seen in the superiotemporal or inferotemporal disc margin, and they extend into the peripapillary NFL. And they are reported to be a sign of disease activity and are associated with progression. So this is very characteristic of glaucoma. Then we have RNFL defects, and they are seen in both glaucomatous and non-glaucomatous eyes. So here, the glaucomatous defects that we often see are wedge defects that are narrow at the disc margin, and they tend to fan out towards the periphery. However, 10% of people can have slit defects that are normal. So slit defects that are normal, they tend to, I mean, the slit defect doesn't reach the disc margin, and they are about less than an arteriole in width, and those are conditions that are considered non-pathological. And however, it is important to understand that there are many optic neuropathies that can result in damage to axons and can cause RNFL defects. So again, consider the whole picture of the patient. These are examples of pictures of RNFL defects. As you can see, there is a wedge shape that starts in the optic disc margin and extends to the periphery in both eyes. And in both eyes, you can see there's a notch right where the wedge defect is. So this is very characteristic of glaucoma. And you can see it a lot better in the red-free filter. So I encourage you to use the green light when examining the optic nerve. Now I'm going to mention a few congenital conditions that might mimic glaucomatous optic nerve damage. Here we can mention the optic disc pits, colobomas, morning glory disc anomaly. They all can have large disc and large cuppings, so sometimes it's difficult to differentiate if they have actually glaucoma or they have like a disc anomaly. And optic disc drusen is another congenital condition that can mimic glaucomatous disc damage. But here, and this optic disc drusen can even cause visual field defects that can mimic glaucoma. But here, if we have a suspicion, then we can use ultrasonography, autofluorescence, and OCT to rule out if they are actual drusen or if the patient actually has glaucoma. These are more pictures. The first picture shows you a coloboma of the optic nerve and with a corresponding arcuate defect and in the visual field. The B picture or the middle picture, it shows an optic disc pit, and this patient has also a neurosensory detachment here seen in the OCT scan, and they can like cause also visual field defects that might mimic glaucoma. And the last one is a morning glory anomaly or morning glory disc. And as you can see, the visual field here shows an enlargement of the blind spot. That's a glaucomatous defect, but it's not actually glaucoma, right? So it's like very interesting. And this one shows optic disc drusen, and as you can see, it's hyperechoic in the ultrasonography, and they can show like this visual field. They can give you defects such as nasal steps, and also like you can see them in the autofluorescence, so that you have several methods to rule them out or to diagnose them, right? Another congenital condition that might mimic glaucomatous optic disc damage is the superior segmental optic nerve hypoplasia, or topless disc syndrome. So these patients usually are characterized by pallor of the superior optic disc, peripapillary scleral halo, and thinning of the superior RNFL. These patients usually have normal to good visual acuity, so it's not uncommon to miss this entity when only like checking the patient clinically. And sometimes the diagnosis is done only when the patient has visual fields done, and you see this really suggestive field of glaucomatous optic nerve damage, but it's actually, again, it's not glaucoma, it's hypoplasia of the optic nerve head. So just to keep it in mind, it's not, I've never seen one actually, or maybe I had never thought of that as a differential diagnosis, but now I'm gonna have it like in my mind. Again, another congenital condition that can mimic glaucomatous optic disc damage is megalopapillas. These are large discs, large cups with no anomalous features. There are two phenotypic variants, the bilateral and the unilateral, and there's no thinning of the neuroretinal rim, and there are no visual field defects. So this is like another group of conditions that might or they can mimic glaucoma and our retinal conditions. So the first one that's mentioned is retinitis pigmentosa and vascular occlusions, BRVO, CRVO, BRAO. So all of these can cause defects in the visual fields that might mimic glaucoma. But I mean, here, since we have like an amazing retina team, if you have any doubts or if you check like the retina, then you will know that it's not actually glaucoma. The defect might be caused by a retina condition. So now we are on to the next category of conditions, and these are neuro-ophthalmological conditions that can mimic glaucoma. And first off, we have intracranial tumors or intracranial space occupying lesions. That was the case of our patients. And there are also inflammatory conditions like optic neuritis that can cause appearance of glaucoma, but they're not actually glaucoma. And some patients can even present with optic atrophy superimposed to a previous glaucoma damage. So, but that's like a very challenging case, and you're supposed to consider like the whole story and the clinical picture. This is a picture of an MRI of a patient who also has a craniopharyngioma. So you can see here that these are very characteristic visual fields that respect the vertical meridian. So this is very suggestive of neuro-ophthalmologic conditions. So you can't miss that. And then we have also hereditary optic disc neuropathies and also ischemic neuropathies that can mimic glaucoma. For example, perinatal asphyxia resulting in hypoxic ischemic encephalopathy, ischemic optic neuropathy, nutritional and toxic optic neuropathies, and traumatic optic neuropathies. So there are also a lot of conditions that can give you or show up with visual field defects that can mimic glaucoma, as I mentioned. For example, arcuate defects can be caused by blepharoptosis, dermatochalasis, SSOH, tilted disc. The arcuate defects can be caused by retinitis pigmentosa, PRP, acute retinal necrosis. Peripheral field constriction or tunnel vision can be caused also in patients, can be seen also in patients who have extensive PRP and retinitis pigmentosa. Patients who can show paracentral defects and sacrocentral defects, they can be patients who don't have glaucoma, but they have cataracts or CSCR and or optic neuritis, and they're patients who show hemianopic or quadrantanopic defects. They are usually patients who have neurological issues, for example, an intracranial tumor or cerebrovascular events. So this is a really cool table that I'm not gonna read because it's a little bit long, but I can share it with you. It's a comparison of the main characteristics of glaucomatous optic neuropathy and non-glaucomatous optic neuropathy. So this is very helpful. And also, these are some recommended indications for neuroimaging. First is when the patient presents with pallor more than cupping, normal IOP, visual field loss that respects the vertical meridian, as we mentioned. When the age of the patient is less than 50 years, you should suspect something else. And asymmetrical loss of color vision, APD, headache, symptoms of hypothalamic pituitary dysfunction, demyelinating optic neuritis, and unilateral or bilateral advanced damage without IOP elevation. So consider neuroimaging in those patients. A brief summary and recommendations for you. Always consider a detailed and meticulous history. Ask about head trauma, history of blood loss, acute blood loss, pattern and onset of visual field loss, the age of the patient, as I mentioned. Young patients, usually causes are more likely to be hereditary, post-traumatic, inflammatory, or infectious. Middle-aged patients, they can have compressive and vascular etiologies. And ischemic causes can be more common in the elderly aged group. Always consider the refractive status of your patient, consider any other symptom and what the characteristics of the symptoms are. Say, the visual loss, how was it? Was it like sudden onset or was it like a long time? Was it associated with pain, headaches, etc.? So always careful retinal examination, as I mentioned, and evaluation of visual fields will always be helpful. This is a very cool flow chart that I found that can help. Again, I'm not gonna read them because they are too long and I think I'm right like almost up in time. So I just wanted to present them to you, and I had the idea of printing them out and like pasting them in the clinic just to have like an easy access to, like, if we have like challenging cases, in case someone has a doubt or we are not sure on how to go with a particular patient. So I just think that they are very nice and complete. So these are my take-home points for you tonight. So finding our way through challenging cases is essential because misdiagnosis might lead to unnecessary treatment and unnecessary testing for the patient. Always suspect that the patient might not have glaucoma or might not have only glaucoma. If there is more visual field loss and faster progression than what you're expecting, considering the IOP of the patient, especially if the IOP is controlled in the patient. Again, and I can't emphasize this enough, pay attention to pallor of the optic disc. And also, this is a very interesting concept that I read, and it's that there can be cases where there can be ticks and fleas on the same doll. What this means is that the conditions are not like mutually exclusive. I don't know how to say it, but I mean, a patient can have like glaucoma and another disease as well. For example, a vascular occlusion or maybe an intracranial tumor and glaucoma. So those are very difficult cases, but if you like pay attention to details, then maybe you can, I mean, we have to crack the cases, right? I always insist in giving the clinical picture a name and a last name. What I mean to say is, if you are suspecting that this patient has glaucoma, for example, then you're supposed to name it. I mean, you're supposed to say, is it primary open angle? Is it angle closure, glaucoma, or pigmentary pseudoexfoliation? Because, I mean, just saying glaucoma doesn't quite cover it. And then you might be probably just giving a diagnosis and it's not actually the diagnosis. So always give the clinical picture the name and its last name. And finally, trust your gut. I mean, sometimes we are not sure and the patient comes in with a diagnosis that was done by someone else, but we are not sure. So if you're not comfortable with the diagnosis that the patient brings in, then you should always like trust your gut and trust your knowledge and keep on studying the patient. And lastly, this is a picture of a bee orchid, and this is another example of mimicry in nature. They look like bees, and that's what helps them attract other bees to pollinate the flower. So thank you so much. I'm really happy that I learned a lot with this. I'm sorry if I was talking too fast, but I wanted to cover everything for you. So thank you. That's all.
Melanie, that's a great presentation. What do you know what happened with the patient?
So not yet. She hasn't come back to the clinic. She came in like last month, I think. So she's probably due to come back maybe this next month, but I'm not sure. We could call her just to see what happened to her.
And you don't have her field.
No, I mean, we didn't have visual fields in the clinic that day, and she didn't do the CERA that we asked for, but she might bring them like later on. Neurosurgery will probably ask for them.
Yeah.
Also.
I wonder if you could detect a temporal defect in the better seeing eye.
Yeah, that would be awesome.
Yeah.
Well, I think it was a great presentation, Melanie.
Thank you.
I agree with you, you know, when you write down the diagnosis, I like to think of it as a second name, and you write in the mechanism of what's going on. That's how I think about it. You know, you got glaucoma, which is, you know, damage to the nerve, then what's causing the glaucoma? You know, is it closed angle? Is it uveitis? Is it neovascular? So I agree with you. That's a great way to think. Andy?
Yes, Melanie, that's amazing presentation. Thank you. I just wondering, like, for the non-glaucoma specialist, when you're looking at eyes with disc head drusen or atrophy or maybe a prior vein occlusion or maculopathies, yeah, how much weight do you put in the OCT, the RNFL, in following progression, given that it's hard to interpret the visual field and it's hard to interpret the nerve appearance in those cases?
So to me, it's a combination of if the patient is not doing very good visual fields, then you can like base your management on the clinic that you're seeing. You can describe the neuroretinal rim. That's gonna like be like a very good starting point for you. If you know that the patient has another condition, you know, like the ones that you mentioned, and also you can base a lot of your follow-up on the IOP of the patient.
Okay.
Yeah, I think those are hard, like disc drusen, because those cause visual field defects. Those cause neurofibril layer thinning. Those even cause, ganglion cell, IPL thinning. So those can be challenging. So sometimes you are treating just elevated IOP, right?
It's
Sometimes just to be on the safe side, if they have elevated IOP in the presence of disc drusen, sometimes it just makes sense to treat that if you think they're at risk of glaucomatous optic neuropathy on top of the compressive.
and then in those cases, maybe just target. I can think of a handful of patients like in my clinic where I just try to get them down to 12, 13, 14, just because 18 to 20 is, I mean, I can't prove that it's glaucoma, I guess. So what on those cases, are you looking for just a normal pressure, or are you looking for a pressure as if those findings were glaucoma? Do you know what I mean? Like
Right.
if
Yeah, look at other risk factors, family history, is their field defect progressing faster than you would expect just from the disc drusen? You got other risk factors, myopia, central corneal thickness would play into that.
Okay.
Everybody else, Jorge and Melanie.
You would consider also vascular factors.
Yeah.
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 But if it was me and I had some optic nerve issue, I would like to have my pressure as low as possible. I don't know if that answered your question, Andy.
I get so the thought being
We're short of surgery.
Yeah.
Yeah, sure, surgery, yeah. But
Right.
Okay.
I was just going to make a comment. First of all, thank you for the great presentation, Mel. And it's such an important and subtle thing when you look at that patient with cupping and you go, gosh, the rim doesn't look right, though. The rim is pale, too, and we've all faced that. I have a unique demographic here in the Central Valley of California. We have a large Hmong population. I've mentioned that before, who was brought here as refugees after the Vietnam War. And a lot of them have severe cupping, but also optic nerve rim pallor. And I've struggled with this over the years and done a lot of workups, and they invariably don't show any CNS lesion, and nutritional factors are always normal when I test them. However, probing the history, I hear almost the same story from all these patients, that they were all in refugee camps in Thailand and received maybe one small bag of rice per day or per week, were nursing and pregnant at the time. And so I've come to the conclusion that I have this cohort of patients that I'm taking care of. I'm treating their glaucoma-ish disease. To speak to Andy's point, I'm still trying to lower their pressure because they have cupping, and what else can I do? But really, it's a nutritional optic neuropathy, I believe, that happened remotely many years ago that, of course, I can't fix. But I just wanted to comment on that. That's kind of a regional thing. So all of us work in these little regions, and we may pick up important patterns that are specific to our populations.
there's a tool on the OCT, which is the angio OCT of the optic nerve, and that can give you perfusion and flow. And it gives you a percentage of how much flow is going into the optic nerve. And there are some papers that describe that below 40% of perfusion, that can be a sign of early glaucoma. They can compare that. It can give you, the OCT can compare different tests, and it can tell you whether there is ischemia, whether there is early glaucoma. So that's also another thing we can start using. Cesar, you have your hand up. Cesar Estrada?
Good morning. Good evening. I don't think so. I apologize if my hand is up, but no, I just sent a message in the chat. But great presentation. Thank you for sharing. It's an interesting case. And actually, I am in the inherited retinal field, and it's good to know the different diagnoses between these cases and retinitis pigmentosa, as you mentioned in your presentation. And it's great. Thank you for sharing this case.
Thank you.
Thanks, everyone. Any other comments? Thank you, Melanie.
That's great, Melanie. Thank you all.
Thank
Melanie.
you. Thank you, everyone. Yeah.
Congrats, Meli.
Gracias.
How
Thank
nice.
That was fantastic.
All right, guys. Thank you.
Hey, thanks. Have a great night, you guys.
Yeah.
All right. Bye bye.